Okay,
Well, my name is Jay Piccirillo, and I'm a professor of otolaryngology at Washington University in St. Louis, and I'm a general otolaryngologist, and I also direct 2 research training programs, and I teach medical students clinical epidemiology and evidence-based medicine. So I do a lot of the clinical research in the department. I've had the pleasure to speak to this wonderful group maybe 5 to 7 years ago. I can't remember what it was about, Agnes and Phyllis, maybe the tinnitus work that I've done. Yeah. So I'm still involved in tinnitus. We have some funding from the NIH to look at tinnitus and cognitive behavioral therapy and using things like cell phones and cell phone responses to help us understand what for each individual person might be a driver of their tinnitus. And then if we can figure that out, maybe direct treatment for that. So that's what I've been doing in tinnitus. And again, I'm really looking forward to today's presentation, having the opportunity to present to this wonderful group. So I'll stop and let Dr. Wick introduce himself.
Hello, Cameron Wick. I am a neurotologist at Washington University. So like Dr. Piccirillo, I'm ENT is my background, but then I spent 2 years specializing in ear and skull base surgery. So from all of you diagnosed with a vestibular schwannoma or acoustic neuroma, you know, the neuro-otologist is kind of one part of the skull base team, along with the neurosurgeon and sometimes a radiation oncologist. I too have had the pleasure of talking with many of you at various meetings, and happy to provide an update on some of the exciting projects we have at WashU, and appreciate Harrison, Dr. Piccirillo kind of inviting me to tag along.
Okay.
Thanks, Cameron. So it's my pleasure to introduce Harrison. Harrison Smith is a medical student at New York Medical College in Valhalla, New York, right outside New York City. And he chose to come to St. Louis and do a year of research with us in the department. And his research is funded through the NIH and our taxpayer dollars. And during the time at WashU, he's conducting 2 clinical research projects that have to do with acoustic neuroma, and he's going to talk about them now. He also is taking coursework in advanced statistics and epidemiology and will be getting a master's degree. And then he'll return back to New York Medical College for his last year of medical school, and then hopefully he'll match into otolaryngology as a residency, where he'll have 5 more years of training. And then if he wants to be like Dr. Wick, he'll probably need at least 2, maybe 3 more years of training. So Harrison looks really young, and thank goodness he is, because he still has a lot of training ahead of him. But it's been a pleasure to have him in St. Louis. And so I'd like Harrison to go ahead and present the 2 projects. And really, I know Harrison will give his thanks also, but I'd like to give a thanks to the Acoustic Neuroma Association, because for project number 2 in particular, your organization's been very, very instrumental to him getting this work done. So I'll stop and let Harrison take over. Go ahead, Harrison.
Yeah, well, thank you for that introduction, Dr. Piccirillo. It's really been an honor to have the privilege of coming to St. Louis and training, learning these skills about clinical research under the mentorship of Dr. Piccirillo and the guidance of the department there at WashU. So it's been a great experience so far, and I can tell you that I've learned so much already this year. I'm going to share my screen and talk a little bit about the work that we've been doing related to these projects for vestibular schwannoma. Like Dr. Piccirillo mentioned, I'm a 3rd-year medical student out of New York Medical College in New York, just out of New York City. I'm going into my 4th year and hopefully going to be pursuing a career in otolaryngology as well. So, as many of you probably know, there are still tons of unanswered questions about acoustic neuromas. This is largely due to the fact that acoustic neuromas are so uncommon, and there aren't many people like yourselves that get diagnosed with these tumors every year. But also due to the fact that a lot of the traditional tools in clinical research, like randomized clinical trials, are difficult to do because of smaller amounts of people and diagnosis in certain areas. At WashU, patients are offered a variety of management options, including microsurgery, gamma knife, and active surveillance. And as a result of this extensive experience managing acoustic neuromas, we've actually been able to develop a database of patients treated at WashU, consisting of over 700 patients from the last 20 years. The reason that we were interested in creating this database is because clinical outcomes are related to treatment of acoustic neuroma are essential in terms of improving patient care in this space so that we can provide better care in the future. Particularly, we're interested in looking at characteristics that are related to tumor control, hearing preservation, treatment side effects, and facial nerve function. One of the things that we are particularly interested in looking at is the fact that patients present with acoustic neuroma with a variety of different symptoms that I'm sure many of you can relate to. People talk about having hearing loss or having ear fullness, imbalance or dizziness, tinnitus, headache, facial numbness are just a few of, I'm sure, many other things that patients noted when they first got diagnosed. Now, the reality is that these symptoms present with different levels of severity, different timings of onset, and are likely related to some of the underlying characteristics of people's acoustic neuromas that are maybe related on a fundamental level to the care. So with information from this database of over 700 patients that we have and their symptom presentation and characteristics of their symptom onset, we're hoping to develop tools that can help identify patients who are more predisposed to desirable clinical outcomes, such as their hearing preservation or tumor control, many of the things that I mentioned before. Fortunately for us at WashU, we have had such a large database. This is one of the largest that we've been able to assemble and look at. So there's lots of promise in terms of teasing out some of the nuances of people's tumor characteristics so that we can push care forward in a more positive direction.
Harrison, before you move on to the second project,
mm-hmm.
Were you going to go on to the second project next?
Yeah, I was.
Yeah, well, I was just going to sort of restate what Harrison said, but maybe try to emphasize what we're trying to do. We believe that the symptoms that the patients with acoustic neuroma present with can provide information about prognosis, about outcomes, and about perhaps maybe what treatments might be better, or even the watchful waiting or surveillance. Are there a set of symptoms that prognosticate maybe a more severe or bad outcome, or are there symptoms that suggest maybe watchful waiting would be an appropriate approach and that treatment's not necessary right away, but close watching? And Harrison, you wanted to share a little bit of what we've been finding with the results with regards to what type of symptoms are related to poor outcomes and good outcomes. This is all preliminary research, and Harrison's continuing to do it, but he's been spending about 8 to 9 months digging through these 700 or so medical records to identify all the symptoms and outcomes, and he's starting to now do the data analysis.
Yeah, one of our preliminary findings so far has been that patients who have sort of a more recent hearing loss and are younger have and also have smaller tumors. I'm sorry, patients who have had recent hearing loss and are younger with larger tumors tend to have worse outcomes as it relates to severe complications in surgical management. Whereas with patients who are older, this is not nearly as dramatic, and patients who are younger with longer hearing loss actually also have even less of an incidence of severe surgical complications that
And let me just add before Dr. Wick does, one of the challenges that Harrison has had is that there aren't that many people who have these severe complications. So it was kind of hard to do some of the analyses, and it's only with a very, very large data set can we even begin to do this, because fortunately the complications are not that severe in numbers. And Cameron, that's something we've been trying to do, as you know, is to look at what type of symptoms at presentation might prognosticate more challenging cases for you all as a neuro-otologist.
And I think the project emphasizes the point that people do come in with a different array of symptoms. Some, they're really driven by the imbalance issues. Some, the hearing loss is debilitating for their quality of life or their performance in noise. And so hashing out what symptoms are important to the patient is really part of our job. And as we get to know our patients, and this type of project can, you know, hopefully add additional guidance to say, hey, if this is your primary problem, the thing that bothers you the most, this is the data that we have on what the different treatment algorithms can offer you.
That's great. And that kind of leads to Harrison's next project, which was the surveillance project. And again, are there some symptoms that suggest surveillance might be an appropriate management strategy? So go ahead, Harrison, talk about project 2.
Yeah, so the other project that we've been working on, and we've called it the active surveillance in vestibular schwannoma patient perspective. And really this project would not have been possible without the partnership of the Acoustic Neuroma Association. We reached out, and the Acoustic Neuroma Association has sort of provided the information about this study to its members, and as a result, we've had tons of responses for people to talk to who have been in this situation of being in an active surveillance. And overall, when patients get diagnosed with the vestibular schwannoma, there are sort of a couple of decision points that happen. The first is when someone is first diagnosed, and whether they're going to decide on choosing active surveillance or active treatment. And from there, after undergoing active surveillance, there becomes an additional decision whether or not to continue their active surveillance or pursue some additional treatment. And so in particular, we are interested in looking at those decision points. And the way that we've gone about this is to conduct patient interviews to gain more insight into the factors that influence these decisions, and what sort of priorities people have when it comes to making the decision to watch and wait, or continue to watch and wait, or, you know, pursue a treatment option. To date, we've enrolled 20 patients in this study, and that's actually been our enrollment goal. And from that, we've conducted interviews with these patients to identify themes in their experiences, so that we can inform future research in terms of identifying what priorities patients have, and what areas they would like to know more about, as well as identify the decision making resources that people used that they found helpful, areas in which these resources could maybe be improved, so that future people who are diagnosed with this can make well-informed decisions, and ones that they feel confident in. So far from our interviews, we've been able to identify a number of themes. One of them has by and large been the fact that online resources such as the ANA have been incredibly useful for people to educate themselves about treatment options and the nuances that accompany them, as well as the importance of connecting with other people who have also been diagnosed with an acoustic neuroma to get their perspective on their experiences, either pursuing treatment or continuing to observe. Because for many of these people, just having that connection has been instrumentally helpful to making their own decisions. Another common theme has just been an interest in understanding the risk factors for acoustic neuroma in general. What sort of things predispose people to getting this tumor in the first place, and what work can be done in the future to identify that. So with that, I just want to thank you all for having us here today to talk about this research, and it's an absolute honor to be here today. So thank you.
All right. So if you can stop screen share. Thank you. Thank you so much, all of you in that. So let's go back, and obviously the doctors and Harrison are interested in what your questions might be about either of the studies. And I guess I'd like to start by asking, are you still looking for participants in your second study, or have you closed that off?
Right now, we've met our enrollment goals, so we're not looking for additional participants at this time.
Okay. Okay. All right. Other questions about the studies in relationship to your own situation, or something there that kind of peaked as far as the possible use of the information? Questions? Yes, Al.
My question is with regard to project number 1 with the preliminary results. Were those findings true whether it was a surgical treatment or radiation, or did they differ?
Yeah, that's a great question. Right now, that those results were specific to patients undergoing surgery. We hope to sort of expand this and look at the radiation group in our database, but we haven't done that analysis yet.
Thank you.
Okay. Other questions?
Harrison, or maybe I'll ask it to Cameron. Harrison, in your database, is it about half and half radiation and surgery or something like that? And Cameron, is that what you would expect?
So our database right now, it's a little bit more towards radiation. Actually, there's about 400 patients who have received gamma knife radiation, 200 patients that have received surgery, and about 100 who have sort of been actively surveillanced over the years.
Okay.
Yeah, I think those numbers, what I usually tell patients is, as a center, we generally have about a third of our patients in repeat MRI with observation, a third go surgery, a third go radiation. Now, when I first see patients, it's usually about 50% choose the observation pathway for a while. And I think that makes sense. There's a lot of information to gather on the diagnosis and your specific clinical situation. There's other team members to meet. And so there are exceptions, but in general, it's not an emergency to undergo the treatment. So we want to make sure that what treatment pathway you choose, it's the right choice for you. And it's our guide to, guide you. It's our job to guide you along that process.
Okay. Okay. I have a question from Judy Leahy.
Yeah, so I can see the chat. The age range for the participants in the second study has been largely between 50 and 65 years of age for the most part.
Okay.
I'd like to know if we were treated at WashU, either with surgery or gamma knife in the past, are we included in that study?
If you were treated at WashU, your records would likely be in this database. The database is de-identified, so there's not any personal information associated with the records, just purely the clinical outcomes. And
Harrison, what are the dates from when to when exactly?
Yeah, so we have from patients collected from 1998 until 2020.
Okay. So over 20 years then. Okay. Other questions about the study?
May I ask a quick question about your observation arm? Have you noticed anything that people are taking for medication that's preventing them from growing further? Have you seen any commonalities that keeps people really just identified as having a neuroma but not progressing where they need treatment with growth?
That's a great question. We haven't looked quite into the medications that people are on when it comes to the active surveillance group. So I don't, unfortunately, I don't have a good answer for you on that.
Harrison, no, but you've just finished the interviews. Do you recall off the top of your head a discussion about different medications these surveillance patients may have been using?
Largely, people don't talk so much about medications that they're on, but more about how it is that they cope with the knowledge of having an acoustic neuroma, how they deal with their symptoms, and sort of more of those things as opposed to treatments that they use.
Cameron, do you recommend any medications to slow or stop the growth?
No, I don't recommend any. I guess as a little backstory, these databases, it is not simply click a couple buttons in the electronic medical record and they magically, fall into place. It's really a time-intensive effort, both setting up the database and pulling it in. And as WashU has gone through different medical records, some electronic, some not electronic, it is challenging to get some of the information. So that's a limitation to any retrospective study where we're trying to pull the data. And this has been various projects for a year or two trying to get these numbers up and accrue this data. Now that we have patient lists and patient data, then we can potentially go through records and look at, hey, in the observation arm, what tumors grew, what tumors didn't grow, and kind of scan medications and those types of things. And some of my colleagues at Harvard have talked about aspirin as a potential growth inhibitor. There's some data I know recently out of UT Southwestern and Dallas talking about metformin, which is a medication for diabetes, maybe associated with growth inhibition. There's also some question about, is there an inflammatory portion of these tumors? And I think the metformin and aspirin discussion are maybe guided at, are they affecting some of the inflammatory part of the tumor? So it's good questions, but I would say even from the Harvard and UT Southwestern data, there's no definitive medication that we can recommend right now to say, hey, this is going to slow the rate of your growth.